This week we're going to start talking about coronary artery disease and the anti-anginal medications that are used to treat. What are the indications? Angina, which could be acute or to prevent angina for prophylactic treatment, as well as other uses such as congestive heart failure, acute MIs, Raynaud's phenomenon, as well as peripheral vascular disease. So currently there are three major classes of anti-anginal drugs that are used in the medical management of angina pectoris. The nitrates, which are short and long-acting, the beta blockers, as well as the calcium channel blockers. So we'll start with the nitrates. What are the nitrates and their mechanism of action? Nitrates relax vascular smooth muscle via the stimulation of intracellular cyclic Digoxin monophosphate production. The major effect of nitrates is to reduce myocardial oxygen demand, primarily by decreasing the preload and to a lesser extent by decreasing the afterload. Nitrates cause major dilatation of the venous beds, and this vasodilatation results in venous pooling of blood, thereby decreasing the venous return to the heart. A decreased venous return reduces ventricular and diastolic volume, and this reduction in preload results in a reduced filling pressure, thus a decreased pressure of blood against the wall of the heart. This reduced wall tension decreases myocardial oxygen demand. A relatively minor effect of nitrates is the reduction in afterload achieved by arterial relaxation. Reduced afterload decreases myocardial work, which in turn reduces oxygen consumption. Another relatively minor effect of nitrates is that they improve the myocardial oxygen supply by optimizing blood delivery via the dilatation of the coronary arteries. They may be an important mechanism in the prevention and treatment of patients with coronary vasospasms. And nitrates also increase the use of coronary collaterals so that perfusion of the inner layers of the myocardium is improved. So what are the evidence-based recommendations for the use of nitrates? For a stable angina, effective long-term single drug treatment regimens include antiplatelet drugs, beta blockers, calcium channel blockers, nitrates, potassium channel blockers. For unstable, potassium channel openers. And for unstable angina, it's beneficial or likely to be beneficial to treat with aspirin or Plavix, which is clopidogrel. Treatment principles. The cardinal points of treatment is to control acute attacks of angina by using nitrates. Long-term management may require antiplatelet drugs, long-acting nitrates, beta blocker therapy, ACE inhibitors, calcium channel blockers, ranolazine, aspirin, statins, and possible revascularization. Patients with symptoms suggestive of coronary artery disease should be referred to a cardiologist for evaluation and treatment. You, as the primary care provider, usually is responsible for following up with these patients who have stable angina. The provider should be prepared to handle acute angina in the office setting and should have a protocol in place to be followed for management of a patient who comes in with unstable angina and an acute MI. prior to the arrival of emergency personnel. So the office should have a plan in place. If a patient comes in with chest pain, you should have nitrates available. Many of the offices have AICDs, and 911 should be called, and the patient should be transferred to the emergency department via an ambulance. The patient should not drive, nor should a patient's significant other or somebody who drove them to the office should not drive them to the emergency room. This should be done by professional individuals who are able to handle a patient if they have an MI. So all adults should be educated regarding the efficacy of risk reduction in preventing coronary artery disease. Risk reduction is a key component of the treatment. The three risk factors for which the greatest effort should be made are to control hypertension, stop cigarette smoking, and treat blood lipid abnormalities. The benefit of regular exercise is so important, and it cannot be overstated. Often physical activity has a positive effect on blood pressure as well as blood lipids, and a tremendous psychological effect as well as overall cardiovascular benefits. Control of these can significantly reduce a person's risk for coronary artery disease. Each of these is important enough to merit a separate chapter in which we'll look at each issue. In addition, the control of diabetes mellitus is extremely important. Obesity and physical inactivity should be approached along with lipid reduction. And again, exercise is important for weight reduction and the regulation of lipids. Dyslipidemia positively is influenced by exercise. Guidelines that are evidence-based in prevention of coronary artery disease include complete cessation of smoking and no exposure to environmental tobacco smoke, blood pressure that's controlled, lipid management, physical activity goals of at least 30 minutes 7 days per week, minimum 5 days per week, weight management with a body mass index of 18.5 to 24.9 kilograms per meter squared, and a waist circumference less than 35 inches for women and less than 40 inches for men. Type 2 diabetes mellitus management should aim to prevent cardiovascular complications, and antiplatelet anticoagulant such as aspirin is recommended in all patients with coronary artery disease unless indicated. The renin-angiotensin aldosterone system, the ACE inhibitors should be started and continued indefinitely with patients with left ventricular ejection fractures less than 40%, and in those with hypertension, diabetes, or chronic kidney disease unless contraindicated. The ARBs are recommended in patients who have heart failure or who have had a myocardial infarction with left ventricular ejection fractures less than 40% or and who are ACE inhibitor intolerant. Aldosterone blockade, the use of aldosterone in post-myocardial infarction patients without significant renal dysfunction or hyperkalemia is recommended in patients who are already receiving therapeutic doses of ACE inhibitors and beta blockers, who have left ventricular ejection fractures less than 40% and who have either diabetes or heart failure. Beta blocker therapy should be used in all patients with left ventricular systolic dysfunction with an EF less than 40%, with heart failure or prior myocardial infarctions unless contraindicated. Use should be limited to carvedilol, metoprolol, succinate, or bisoprolol, which have all been shown to reduce mortality. Patients should receive influenza vaccines, and Those patients with depression for recent coronary artery bypass, graft surgery, or myocardial infarctions, it's reasonable to screen for depression and treat appropriately. Patients, all eligible patients with acute coronary symptoms or whose status is immediately post-coronary artery bypass surgery or post-PCI should be referred to a comprehensive outpatient cardiovascular rehabilitation program, either prior to hospital discharge or during the first follow-up visits. For chronic stable angina, management assumes that the patient does not have other illnesses present. However, patients with angina often have many other problems which affect how the angina is treated. You should always start with non-pharmacological lifestyle modifications after and only after the angina is controlled. Should manage aggravating factors, treat other problems and risk factors aggressively. All patients should receive rapid-acting nitrates and should be instructed for their use and treatment in an acute angina attack. Patients should receive long-acting nitrates. These should be considered. The main limitation of these are intolerance, which can be limited by providing a nitrate-free period of 6 to 10 hours each day. Beta blocker therapy should also be considered in all patients with angina. These are the only anti-anginal agents shown to prevent death in patients with angina. A careful evaluation of the patient's risks and indication for beta blockers should be conducted, and allow 1 to 2 months for a drug trial with the beta blockers to adjust dose and monitor for a therapeutic response and adverse reactions. ACE inhibitors should be used for all patients with coronary artery disease without contraindications in addition to standard therapy. They, too, decrease the risk of cardiovascular death, along with calcium channel blockers. These are the medications of choice for coronary vasospasms. They may also be useful in stable angina if nitrates and beta blockers have failed. Use of diltiazem or verapamil in patients unable to tolerate beta blockers has been found useful. Short-acting nifedipine in moderate to large doses can causes an increase in mortality in patients with unstable angina or who are recently post-MI, so you should not use these drugs. It's recommended that aspirin or antiplatelet agents, unless contraindicated, are given. Every patient with coronary artery disease should be on an antiplatelet drug. They may take an aspirin, 81 milligrams to 325 milligrams daily, and many patients will have been prescribed antiplatelet or platelet aggregation inhibitors such as Plavix by their cardiologists. Ranolazine may be used in patients who continue to experience angina despite adequate treatment with nitrates, beta blockers, calcium channel blockers, and ACE inhibitors. These should be done only under the direction of the cardiologist. Revascularization procedures are also indicated in many of these patients. They include coronary artery bypass grafting, percutaneous transluminal coronary angioplasty, and stenting. Nitrates are given on a routine basis for these patients to prevent anginal episodes. Angina prophylaxis requires the long-acting transdermal patch or an oral sustained release tablet or topical ointments. A transdermal patch is often used because of the ease of administration. Dosage is measured as release rate in milligrams per hour, and the usual starting dose is 0.2 to 0.4 milligrams per hour, which is then increased or decreased depending on the patient's therapeutic response and whether the patient is having adverse effects. Transdermal patches are more convenient but more expensive than the oral nitrates. Oral nitrates are effective, safe, and economical. The oral nitrates most commonly used is isorbide mononitrate. Isorbide dinitrate is also available. The oral nitrates experience the first pass phenomenon, in which large amounts of the drug are immediately metabolized by the liver. This means that larger doses are required to obtain a therapeutic effect. Alternative routes of administration, such as transdermal patches and buccal tablets, were developed to avoid this phenomenon. Tolerance of nitrates is also an issue. To prevent tolerance, it's necessary to interrupt therapy for 8 to 12 hours a day. The usual method is to take off the patch or stop the medication in the evening and then restart in the morning. The problem with this is that early morning has been found to be a dangerous time for ischemic effects and MI, and to avoid this risk, nitrates should be omitted for a quiet period during the day. Another anti-anginal agent may be necessary during this nitrate-free time if the patient continues to have symptoms. For patients with chronic angina who continue to experience angina despite adequate treatment with nitrates, ranolazine may be used in combination with amlodipine, beta blockers, nitrates under the direction of a cardiologist. For acute attacks, many of you have treated patients with sublingual nitroglycerin. You give nitroglycerin sublingually at 3 to 5 minute intervals for up to 3 doses. If angina is worse or is unimproved 5 minutes after the first dose, EMS should be notified and the patient should be transferred to the emergency department. Give oxygen, usually 2 liters per minute via nasal cannula. Have the patient chew a regular aspirin, 325 milligrams, while waiting for an ambulance to arrive. Rest the patient and reassure the patient that the ambulance will be here and bring them to an appropriate facility in which they can monitor their symptoms. And it's important that the patient receive thrombolytic therapy as soon as possible, preferably within the first 1 to 3 hours of an MI. So this is why we stress the importance of calling 911 and getting these patients transferred to the emergency department. Pain management should be administered as well. The use of morphine or other agents to achieve pain relief is often required. Nitroglycerine education, it's very unstable, and great care must be taken in handling and storing this medication, or it may not be effective when the patient needs it. Nitroglycerin breaks down rapidly and loses its potency. Sunlight will speed up this process. Even under the best storage conditions, all types of nitroglycerin lose their strength at about 3 months after the bottle has been opened. A new prescription should be obtained every 3 months and oral medication discarded. Patients are reluctant to throw away medication that they've had to purchase, but the nitroglycerin is fairly inexpensive, and you need to stress to the patients that they really need to discard this medication, because if they have chest pain, it will not be effective. Medication should be stored in the original dark glass container, and remove all cotton, and keep the container tightly capped and out of the sunlight. Storage in a plastic or cardboard box allows the nitrate to be absorbed into the container material. If cotton plugs remain in the top of the medication container or other drugs are stored with the nitroglycerin, the nitrate will be absorbed. Refrigeration does help to preserve the medication and slow deterioration. Natural and predictable side effects of taking nitroglycerin include flushing of the face, a brief throbbing headache, increased heart rate, dizziness, and lightheadedness, especially when one changes positions rapidly. The headache usually lasts no longer than 20 minutes and may be relieved by analgesias such as Tylenol or acetaminophen. Patients should rest for 10 to 15 minutes after the pain has resolved, and they should notify a healthcare provider if blurring of their vision, persistent headache, or dry mouth occurs. There is no therapeutic value in not taking the nitroglycerin for anginal pain, and it may prevent damage to the myocardium. Remember, time is muscle, especially for the heart. If the medication seems to be less effective after it's been taken for a while, the patient may be developing a tolerance to the drug and should notify their provider. The patient should keep a record of the frequency of the anginal attacks and the number of pills taken and any side effects, and should bring this record to each appointment. The patient should use nitroglycerin in anticipation of situations in which they can predict an anginal attack. Taking the medication before an activity may prevent or reduce the degree of pain. This is only for patients who have a frequent chronic angina. Patients should not change nitroglycerin products without notifying the healthcare provider, and combined with this drug, alcohol may lower blood pressure and should be avoided. Again, patients should not stop taking this medication abruptly and should notify their provider if they're having side effects. For the use in an acute attack, the nitrates are taken at the time of the anginal attack. You should select a fast-acting nitrate. The most common form is a sublingual. Translingual spray is also acceptable. The usual dose of the nitroglycerin tablets is 0.3 milligrams, 1/200th of grain, to 0.4 milligrams, 1/150th grain, given sublingually. Smaller doses, 0.3 milligrams for small, frail, and or elderly patients is available. You can increase the dose to 0.4 to 0.6 milligrams if not completely effective. Remember that sublingual nitroglycerin is rapid active, convenient, and relatively safe, as well as inexpensive. The spray is equally effective as the sublingual tablet, but is more expensive. Translingual spray may be more convenient for patients who have difficulty handling the small tablets, especially in a stressful situation when they're having pain and they're also scared. It's also more stable, and its effects will last longer than those of the pills. The translingual spray should be sprayed onto or under the tongue, not inhaled. Have the patient take the medication as soon as the pain is experienced. The patient should lie down and rest. The drug should be effective within 1 to 2 minutes. If the pain is worse or not relieved after 5 minutes, the patient should be notifying EMS, and a second tablet should be administered. If the pain is not relieved within 3 to 5 minutes, a third pill may be taken. And if the patient is having an anginal episode at the time that they come to see you, an EKG would be effective while waiting for EMS to arrive. The effectiveness of the nitrate should be evident on subsequent EKGs. Fast-acting nitrates can be given before a stressful episode, such as exercise or sex, to prevent angina. For the sublingual tablets, when patients having an acute attack, the patient should take 1 tablet sublingual as soon as the pain is experienced. They should not chew or swallow this medication. They should let it dissolve under their tongue, lay down and rest, and if the pain, again, is not relieved within 3 to 5 minutes, a second tablet should be taken and EMS should be called. A third pill may be taken if chest pain is not relieved after the second dose. Again, if the pain is worse or unimproved after 5 minutes, the patient needs to be seen in the emergency department. Burning under the tongue after sublingual medication is taken is not always a reliable indicator that the drug is still potent. Because some nitroglycerin products are provided in much purer forms than others, they do not always produce the characteristic throbbing headache. For the translingual spray, this is a less popular but equally effective means for administering sublingual nitroglycerin and is given by a metered dose spray. The spray dispenses approximately 200 doses of 0.4 milligrams of nitroglycerin. It has a shelf life of 2 to 3 years and does not require refrigeration. inform the patient to take the spray only when laying or sitting down, because this is a highly flammable product. The patient should not be around cigarettes, and avoid using the spray around fire or sparks. For the transdermal patch, for transdermal application, select a hairless spot or clip the hair and apply adhesive pad to the skin. Washing, bathing, or swimming does not affect this system, but the patient should be informed not to cut or tear the patch. If the patch should come off, the patient should discard it and place a new patch on a different site. They should use nitroglycerin patches in a safe place, especially out of reach of children. For the topical ointment, the patient needs to spread a thin layer on the skin using applicator and the ruler. They should not rub or massage the ointment into the skin and wash off any medication that may have gotten onto the hands. The tube should be kept tightly closed and should be discarded. The paste should be discarded in a safe place, again out of the reach of children. For patient variables, first, how to monitor. You need to encourage the patients to keep a record of their medication use. The record should be brought to appointments and reviewed. You should evaluate the record patterns for increased frequency, multiple dosing to eliminate symptoms, or changes in activity that produce the angina and point to worsening anginal status. Decreased frequency of anginal episodes will document the efficacy of the nitroglycerin. Patients whose episodes of angina do not decrease in number should notify their provider. Patients who use several drugs to control angina should have cardiac enzymes and electrolytes monitored at least every 3 months, and they should be followed by a cardiologist as well. For variables, geriatric patients, older patients are at increased risk for syncope with the administration of nitroglycerin, and make sure the patient is seated or lying down before the nitroglycerin is administered. Geriatric patients usually require a lower dose of these nitrates. For pediatric patients, safety and efficacy has not been established. For pregnancy and lactation, these are considered category C. So the safety of use in pregnancy has not been established. For gender, the effects of ranolazine on angina frequency and exercise tolerance is considerably less in women than it is in men. So now we're going to move on to look at heart failure and digoxin. One of the oldest and most widely prescribed primary care medication is glycoside digoxin. The principal indication for digoxin is heart failure. It is used for systolic heart failure, not diastolic, because of the inotropic properties. It is also used as an antiarrhythmic to control ventricular response to atrial tachycardias or tachyarrhythmias because it's an AV nodal blocker. Digoxin is the only glycoside that is in common use and is the only one that we'll talk about. Although digoxin remains only one of the drugs used in the treatment of heart failure, its wide usage throughout the world, low cost, and narrow therapeutic window require the clinician to understand how and when this product is used. Hospitalizations due to heart failure have decreased in the United States, and this may be due to better control of the patient's risk factors. Patients with heart failure commonly take at least 2 medications, a diuretic as well, and an angiotensin-converting enzyme inhibitor. And the potential for toxicity or lack of efficacy is the major disadvantage of digoxin use. Because it has a long half-life and a very narrow therapeutic window, patients treated with digoxin may easily become toxic. The elderly and those who are renally impaired are especially at increased risk for cardiac rhythm disturbances as well as for toxicity from digoxin. Digoxin-induced arrhythmias must be differentiated from digoxin-treated ones, and the dose must be decreased, not increased. Indications for digoxin include heart failure, congestive heart failure, or also called heart failure. Now it's differentiated between systolic heart failure and diastolic heart failure, atrial fibrillation, as well as atrial flutter. Again, digoxin is used for systolic heart failure, not diastolic, because of these inotropic properties. Digoxin has an inotropic effect on cardiac cells caused by enhancement of excitation, contraction, coupling triggered by membrane depolarization. Excuse me. It acts at the cellular membrane by inhibiting the sodium-potassium pump, thus causing an increase in intracellular sodium. The increase of the sodium-calcium exchange and subsequent calcium accumulation in the sarcoplasmic reticulum causes activation of cardiac contractile proteins, actin and myosin as well. The overall result is increased force of contraction of the cardiac muscle. So to summarize, the cardiac glucosides increase the force of myocardial contraction. They depress the sinoatrial node by stimulating vagal activity. They prolong conduction to the AV node via a vagal stimulation. They increase the refractory period of the AV node and increase peripheral resistance. The heart rate is slowed both vagally and extravagally. And in heart failure, digoxin increases cardiac output and produces mild diuresis, helping to relieve the symptoms. It's most effective in failure caused by decreased left ventricular function and low output syndromes. Digoxin is less effective in high output syndromes of heart failure, such as bronchopulmonary insufficiency, anemia, infection, and hyperthyroidism. Rapid arrhythmias such as atrial fibrillation, atrial flutter, and paroxysmal atrial tachycardia may provoke pulmonary edema. Oral digoxin maintains tachyarrhythmia suppression. Treatment principles, evidence-based recommendations, improvement in symptoms are mostly by adding ACE inhibitors, angiotensin receptor blockers, beta blockers such as metoprolol, bisoprolol, and carvedilol, and digoxin in patients already receiving diuretics and ACE inhibitors, as well as diuretics. Prolongation of patient survival has been shown in patients who have taken ACE inhibitors, ARBs, if the ACE inhibitors are not tolerated, beta blockers, hydralazine, and nitrates, especially in African Americans. The aldosterone antagonists, spirolactone, and have also been shown to improve survival in selected patients. The cardio points of treatment, ACE inhibitors are usually contraindicated, or ARBs if ACE inhibitors are not tolerated. Beta blockers, especially for diastolic heart failure, begin when the patient is stable on an ACE inhibitor. Digoxin is used for systolic heart failure and atrial fibrillation, and spirolactone if the previous drugs are not effective, are useful. Nitrates and hydralazine are only used in African American patients if they are unable to tolerate the above regimen. Calcium channel blockers such as felodipine and amlodipine only are used if needed for angina or hypertension, and if the ejection fraction is preserved greater than 40%. These patients should also be on a strict salt restriction. For most patients with heart failure, loop diuretics are normally administered for fluid retention. Furosemide is more effective than the thiazide diuretic, especially in patients with renal insufficiency. This is usually started at 40 milligrams daily or 20 milligrams for the small, frail, or elderly person. The dosage is then gradually increased until excess fluid retention is relieved. The dosage of furosemide needs to be maintained. Needs to maintain a patient is often less than needed during an acute exacerbation of heart failure. Therefore, consider decreasing the dosage after an acute episode. For example, if the patient is on 20 milligrams per day, when they have an acute episode, you increase it to 40 milligrams a day. When their symptoms resolve, then change them back to 20 milligrams per day. You must always monitor for dehydration as well as hypokalemia when the patient is on furosemide. Metalozone may be added if patient is resistant to furosemide. ACE inhibitors or ARBs in all patients should be used unless contraindicated. You should add an ACE inhibitor after the diuretic has been taken. These drugs should be used in stage 1 heart failure before structural abnormalities develop. And it is important to make sure that the patient is not overly diuresed before an ACE inhibitor is started. If the patient is dehydrated when started on an ACE inhibitor, the patient may develop acute renal failure. A limiting factor for the dose of these drugs is hypotension. If the patient develops a cough from the ACE inhibitor, you should change to an ARB. Start with very low doses and titrate up, especially slowly every 1 to 2 weeks if the patient is elderly, small, or hypotensive. No difference has been noted between ACE inhibitors. They cause regression of left ventricular hypertrophy, they decrease the blood pressure and prevent or modify cardiac remodeling, and are useful in both systolic and diastolic failure. Again, the African American patients are less responsive than other patients to these ACE inhibitors, and you need to monitor this closely. Beta blockers are used in all stable minimal fluid retention patients unless contraindicated. Beta blockers decrease the heart rate, increase diastolic filling time, decrease oxygen consumption, lower blood pressure, and cause regression of left ventricular hypertrophy. They are effective in both systolic and diastolic failure, but are of increased importance if diastolic failure is caused by increased diastolic filling time. Bisoprolol, carvedilol, and sustained-release metoprolol have demonstrated effectiveness in treating these patients with heart failure. Metoprolol and carvedilol are the most commonly used. Digoxin is also used, again, if needed, for treatment of patients with systolic heart failure. Additional medical conditions in which digoxin may be useful include patients with atrial fibrillation and diuretic failure. If these medications are not sufficient to control heart failure, additional drugs may be given. For example, spirolactone, an aldosterone antagonist, are effective in lowering cardiovascular-related mortality in patients with moderate to severe heart failure. They are effective diuretics to help minimize the risk of hypokalemia associated with the use of furosemide. Spirolactone is effective in severe systolic failure because they are potassium-sparing drugs. They may cause hyperkalemia and should be avoided, particularly in patients with renal insufficiency. Potassium levels must be monitored closely in these patients. Nitrates and hydralazine are used if the patient is unable to tolerate ACE inhibitors. A combination of nitrates and hydralazine has been approved for the use in African American patients only. Calcium channel blockers may be useful in diastolic heart failure related to hypertension, but can worsen systolic heart failure. Use of long-acting dihydropyridine, such as amlodipine or felodipine, only is recommended. Again, to determine whether the patient has systolic or diastolic heart failure, an echocardiogram is necessary and should be performed. It should be instituted by their cardiologist. Salt restriction is important. Excess salt leads to fluid retention as well as worsening symptoms. Patients are at high risk for hypokalemia when on a high salt diet. This can be a problem, especially in the frail elderly, because easily prepared foods such as canned soup and frozen dinners have a very high salt content. So you need to educate your patient. So what are our pharmacological goals? The treatment goals include normalizing blood pressure, promoting regression of left ventricular hypertrophy, preventing tachycardias, treating symptoms of congestion, and maintaining atrial contraction. The most common drugs administered to patients with heart failure, again, include diuretics in patients with fluid retention. Furosemide is more effective than the thiazide diuretic, especially in patients with renal insufficiency. Again, start at 40 milligrams daily or 20 milligrams for small, frail, or elderly patients. These doses should be gradually increased until excess fluid retention is relieved, and dosage of furosemide needed to maintain a patient is often less than needed during an acute exacerbation. Again, consider decreasing the dose after an acute exacerbation, and always monitor for dehydration and hypokalemia. ACE inhibitors or ARBs in patients, unless contraindicated, add the ACE inhibitor after the diuretic has been taken. It's important to make sure that these patients are not overly diuresed before the ACE inhibitors are started. If the patient is dehydrated when they're started, acute renal failure may result. Beta blockers in the stable patients, unless contraindicated, these decrease the heart rate, increase diastolic filling time, decrease oxygen consumption, lower blood pressure, and cause regression of left ventricular hypertrophy. Effective both systolic and diastolic heart failure, but is more important in diastolic failure if caused by increased diastolic filling time. Bisoprolol, carvedilol, and metoprolol are the most common. Again, Digoxin added if needed for treatments with systolic failure, as well as patients in atrial fibrillation and diuretic failure. Spirolactone, aldosterone antagonists, effective in lowering cardiovascular-related mortalities in patients with moderate to severe heart failure. They are effective and help minimize the risk of hypokalemia. Nitrates and hydralazine if patients are unable to tolerate ACE inhibitors, and approved for use in African American patients. Calcium channel blockers for diastolic heart failure related to hypertension, but remember this can worsen systolic heart failure. Use of long-acting medications such as amlodipine and felodipine only. Certain drugs can exacerbate heart failure and should be avoided if possible. These include nonsteroidal anti-inflammatories. These drugs can cause sodium retention and peripheral vasoconstriction, thereby decreasing the efficacy of diuretics and ACE inhibitors. Antiarrhythmic agents, except amiodarone, depress cardiac function. Some can cause fluid retention and are contraindicated in stage 3 and 4 of heart failure. Patients in diastolic failure are sensitive to fluid depletion, which can cause decreased preload and stroke volume. They should not receive digoxin. End-stage heart failure requires careful control of fluid retention without causing the dehydration. A patient should be referred to cardiologist for implantable defibrillators or cardiac transplantation as appropriate. End-of-life care should also be discussed with the patient as well as family for end-stage heart failure. The administration and dosage of digoxin has changed dramatically over the past few years. In primary care settings, slow digitation rather than a loading dose is generally recommended because of the risk of toxicity. It may be achieved within 1 week with the use of small daily maintenance doses. If renal function is poor, modification of the dose is required. Digoxin is excreted extensionally unchanged, so levels can quickly reach toxic proportions. As clinicians, you should be aware that the generic digoxin marketed by different companies may not be bioequivalent to the branded digoxin or lanoxin. You should write the prescription for the trade or generic medication that you desire, and then write on the prescription no substitution or brand medically necessary. The clinician may have to contact the pharmacy as well directly to ensure that the medication is dispensed each time is the same medication. The patient should be instructed to make certain that they receive the same product, whether brand or generic, each time the prescription is refilled. Digoxin has a half-life of 36 hours, so it takes 5 to 6 days to achieve a steady state. Start with a low dose and increase in 2 to 4 weeks if therapeutic effect is not achieved and the patient is not toxic. You should measure digoxin levels monthly until stable, and then every 6 months thereafter. Digoxin, once initiated, is often a lifetime drug. Occasionally, a patient in heart failure or arrhythmia may stop taking digoxin if the precipitating factors for the heart failure or heart problem can be eliminated. The drug may be stopped abruptly without adverse effects, but the long half-life allows the drug to be excreted over approximately 6 days. So how do you monitor this drug? You need to monitor for a therapeutic effect, monitor the patient's clinical response to digoxin, not just serum drug levels. If therapeutic response may be achieved at a subtherapeutic drug level of 0.5 to 0.8 nanograms per milliliter. To monitor for therapeutic effect when digoxin is given for heart failure, evaluate both signs and symptoms of the heart failure. Patients with heart failure should have a gradual disappearance of subjective symptoms. In physical exam, you should monitor their weight, pulse rate, heart sounds, JVD, breath sounds, and pedal edema. To monitor therapeutic effect when given for an arrhythmia, you need to monitor the ventricular rate. The patient may also be aware of rapid or irregular heartbeats, lightheadedness, or dizziness. How do you monitor for toxicity? You need to be alert to early signs of toxicity and must obtain a serum level. The digoxin levels greater than 2 nanograms per milliliter indicates toxicity, although some patients may become toxic at lower doses. Serum levels should be drawn at least 6 to 8 hours after the last dose and ideally just before the next dose. Hypokalemia is a risk factor for the development of arrhythmias, even in patients with a therapeutic range. So remember to make sure that the patient does take potassium or eats foods high in potassium if they're on diuretics as well. The earliest signs of digoxin toxicity are subtle and are easily ignored by the patient. These include increased fatigue, visual disturbances, sinus bradycardia, anorexia, weakness, and nausea. EKGs may show digoxin effect, which it's common to see nonspecific ST segment depression or T-wave flattening. Patient variables. For geriatric patients, you need to use caution in the elderly, especially those with renal impairment. Small body mass and decreased muscle mass require reduced dosage because of the wide distribution of digoxin in the tissue. Dose is based on lean body weight. Heart failure is different in patients older than 75 years. In the incidence of diastolic failure is higher, and almost all patients have significant comorbidities. Patients with decreased muscle mass and reduced renal clearance require lower starting and maintenance doses. A constant vigilance over time is required as renal function and body mass change with the aging. For pediatric patients, the use of digoxin in children requires extra caution, lower doses, and close monitoring. Newborns exhibit a variable tolerance to digoxin. For patients who are pregnant or lactating, this is a Category C drug. Its safe use in pregnancy has not been documented. Digoxin does appear in the breast milk, so a possible contraindication to its use. Gender: women on digoxin with heart failure seem to be at somewhat greater risk of death from all causes. For patient education, remind the patient to take the drug exactly as directed by the healthcare provider. If a dose is forgotten, it should be taken as soon as it is remembered. If it's close to the scheduled time for the next dose, the patient should not take the missed dose or double the next dose. It's important not to switch from the trade to generic forms. They may not be the same, and make certain when getting a prescription filled that the same product is received each time. For safety reasons, periodic blood tests must be performed to ensure that the drug level is kept within specified limits, and remind the patient that because digoxin slows the heart rate as it strengthens contractions, they should not take the medication if the heart rate is very slow. The patient should be taught how to take their pulse, or family members need to be instructed. The patient should not take digoxin without consulting a healthcare provider if the pulse rate is lower than 60 beats per minute. This is often less in the hospital, but at home, the patient should have at least a heart rate of 60 beats per minute. The patient should not take over-the-counter medications, especially antacids, cough, cold, allergy, or diet drugs without first talking to their provider, and they should report new or unusual symptoms such as loss of appetite or increased fatigue. These may be two key symptoms that should be reported immediately. Digoxin will kill pets and children, so they need to keep it out of reach of the children and others for whom it is not prescribed. Patients should carry an identification bracelet or card stating that they are taking this medication. They also need to reduce their overall salt intake. They need to avoid high sodium foods, including salted snacks, pork, luncheon meats, and processed cheese. They should not add salt when cooking, and do not use extra salt at the table. Remind them that frozen dinners also have high salt contents, so they should avoid these if possible. They should not use salt substitutes because these are potassium chloride and may cause hyperkalemia.